Okay. Julie Griffin, Tennessee Medical Association, members of the committee. I want to thank you all for having us here today. Before I entered it, obviously, hopefully, we'll allow y'all to talk to Dr. John Hale, TMA president. I just wanted to mention a couple of things about the piece of legislation before you. TMA brought this bill because we had been hearing for a number of years about the nurses' desire to bring a bill which they call full practice authority, but which is more commonly termed in physician communities as independent practice. Basically, removing any requirement that a nurse must have a formal relationship with a physician. TMA does not believe that that is the way healthcare is going. With the formation of accountable care organizations, patient-centered medical homes, and even TennCare's payment reform, coordinated care is the way healthcare is moving in the future. And it was not something we felt was a positive outcome for patients to start creating additional silos in the healthcare community. TMA modeled this bill after something that recently passed, well, basically a couple of years ago, passed in Virginia as a coordinated care model, team-based, physician-led care model. There has been a lot of discussion about the task force bill that Representative Faison has, and our members looked at that very closely. We've been asking to sit down with the interested parties, the TNA, for over 2 years to talk about the things that we could work on jointly. And I think that the Nurses Association would agree that I have said that. But every time they came back with a bill that talked about independent practice, and that was not something that our members considered friendly and was not willing to come to the table on an independent practice bill. But we had told them everything else was open. We want to make it easier for physicians to be able to work with nurses across the state. We cannot, the healthcare system will not survive without our advanced practice nurses in the future. We recognize that. The other thing that made us a little bit tenuous about the task force was, even in their own words of their calls to action that they sent out, they have said, secondly, SB 1979, House Bill 2088, which is the task force bill, calls for forming a task force consisting of stakeholders from across the state that will explore full practice authority. So our members did not feel that the task force goal was to find ways to work together, but to explore full practice authority, which was not something that our members could adopt. So therefore, we decided to run this bill. This bill does several things, and I'm going to quickly go through it.
Please.
Quickly, I promise. It does away with the supervision of APRNs and creates a relationship of collaboration, something the nurses have asked for a number of years. It changes APN to APRN and codifies that all advanced practice nurses, including CRNAs, certified nurse midwives, nurse practitioners, and clinical nurse specialists, may prescribe. That is something else that we've put into our bill. It allows for nurses to practice to the full extent of their training, but it just requires them to also be a part of a healthcare team that includes a physician. It allows the Board of Nursing to set the minimum requirements that a physician team member would have to provide on non-complex conditions of patients. Right now we have a one-size-fits-all approach. This would move to a condition-based, how much involvement the physician would need to give. Then it would allow the BME to set the minimum requirements for physicians for those services that are deemed complex. Now, one of the things I have seen in the things that the TNA has sent out is there's concerns about some of the things we have deemed complex. I will admit
on the bill, please.
Okay. The language of the bill does mention some of the issues of, say, obesity. It was never the intent of the language to address true nutrition types of issues and dealing with weight loss. But the weight loss clinics that are being created out there, where you have unsupervised mid-level providers that are providing a lot of injections of hormones, a lot of things that is probably not common practice and good care. We wanted more oversight of that. That's why we had put that in there. Needs to be cleaned up in the bill, I admit. So the main thing we wanted to do, though, in changing how we deal with this is we have a whole lot of issues that are coming before this General Assembly, including the issues of pain clinics. Hormone replacement was a bill that we had to bring a few years ago. We've had to deal with med spas. We've mentioned the weight loss clinic, and one of the latest things we've heard are people using stem cells for pain, where we have basically these clinics and these cottage industries that are popping up that we cannot go after the supervising physician on because the way the statute is written. Right now, anything dealing with supervising physician has to be jointly approved by the Board of Medical Examiners and the Board of Nursing. That is why we brought this bill. And with that, I want to let Dr. Hale speak.
Okay, well, Ms. Griffin used a lot of your time, Dr. Hale. I understand that. So I hope you understand that. Dr. John Hale, you're recognized.
Sir, I'm married. I understand that.
Yeah.
I'd like to thank you first for your time and your commitment to the state. I will be brief and I will be concise. As Julie said, our bill was brought in response to the nurse bill. We didn't want to be the group of no. We wanted to get something that would work together so we could have quality care in Tennessee. And we feel like our bill is that framework that we can start with. Our current situation is not working. This bill is set up on a bill that's working in Virginia. They've had good success with it. This is not a turf war. To the outsider, it seems that way. We want access to good quality care, and we think that this would encourage that. I don't have to remind this group that in 1830, state legislature formed the TMA. You are our creators because you want us to give advice on health care issues. We believe that our bill creates a safety net. It's good medicine because we believe a degree does not mean competence, whether it be a nurse practitioner degree, even where it be an MD degree. But we think that our more knowledge, more training, and as the physicians on the panel would know, there is a weaning down process, specifically organic chemistry, comparative anatomy, and biochemistry. Our current situation, as I said, is discouraging primary care in the state. We've got to do something about that. We've got to have more people going into family practice, pediatricians, internal medicine. Currently, we have a lot of upside-down arrangements in the state where we have bad docs that are rubber stamping and not checking out things the way they should. Our bill would work towards that. We're willing to work with the nurses. As Julie said, we've tried to work for the last several years with them. We need the nurses. We need the nurse practitioners. Our goal is good, quality access care, and we feel like that our bill would be a good framework for that to start. And as I've talked with some of you now, I think some of you may have some questions, so I guess I'm ready for the fun to start.
Dr. Hill, thank you. Do any questions? Representative Hill, you're recognized.
Thank you very much, Mr. Chairman, and thank you for taking this bill out of order, and thank you to Dr. Hale for being here. We talked a little bit at my office before the meeting, which I think was about 8 hours ago. I
only have to be at the office at 8 o'clock in the morning, so I'm okay.
So we got some time, right? When I take a look at your bill, I've got a lot of concerns, and I'd like to go through those, if I could, please. It's my understanding that there are several organizations that have some major concerns with your legislation, including the Department of Health, many dentists across the state, the federally qualified health centers, the nurse practitioners, the CRNAs, basically the entire continuum of care in the state of Tennessee has some real problems. I want to go through some points here. Under your proposed House Bill 861, this would devastate the CRNAs in the state of Tennessee. This bill does away with the APN grandfathering provision in the Nurse Practice Act under TCA 63-7-126D. That means that any CRNA licensed in Tennessee and holding a national specialty certification prior to 2005 will no longer be exempt from the requirement of a master's degree, despite the fact that they could have literally 11 years or more of experience. A CRNA's ability to administer, dispense, or prescribe pharmaceuticals would be limited unless it is expressly delegated, which is interesting considering that the CRNAs have always, in modern times in the state of Tennessee, been allowed to do those things with none that I know of recorded problems. Every APRN, it says in your bill, shall be required to practice as part of a patient care team and would only be allowed to render treatment, including the administration, prescribing, and dispensing of pharmaceuticals as part of the patient care team. Well, that affects CRNAs especially in many different practice settings. CRNAs are not just in the hospital, they're not just in the operating room, they're in doctor's offices, as you well know. They are healthcare professionals that deliver safe and quality care. And to have them targeted in this bill, I'm hoping is an oversight. I'm hoping that it's not intentional, but excuse me, these are real ramifications of this bill. Routinely, a CRNA practicing in a hospital or a surgery center can work with several physicians or surgeons to deliver anesthesia. So in your bill, questions such as, would the CRNA be required to have a written practice agreement with each physician for each practice setting? Would that be required?
No, sir. And can I address what you
Please.
said so far?
Please.
Okay. I've talked to Wayne Barker. He's a dear friend of mine. Judy Barker used to be a member of this house and well respected. And he's brought up these very comments to me. And I told him we had no concern over what he's been doing or what's been doing with him. That has been working very well. There are a lot of underserved areas where CNRAs are the only ones doing that. We don't want to interfere with that. They're doing a great job, an essential job. But what we don't want is pain clinics on the side of the corner where there's nobody supervising them, doing pain blocks, nerve blocks, so forth and so on. As far as going back to the surgical centers, if you have a medical director there, they could have that agreement with them. That does need to be cleaned up, and I'm glad you brought that out.
What about CRNAs at dental offices?
I think that we can certainly work with them as long as there's some sort of backup as a medical doctor or somebody on staff there around by that they had an agreement with just to provide care.
Help me understand, if you could quickly walk us through why, after decades of CRNAs being able to work with the doctors, with the physicians, with the anesthesiologists, all of a sudden there's this great concern that CRNAs are killing people. What's the problem? What am I missing here? Why all of a sudden do we need these extra layers when they haven't had them in the past?
We don't need for the ones that are good. The problem is we're going to see an influx of this going on. And I don't have to tell you about the pain problem we have here in Tennessee. You hear about that all the time. You read about it in the newspaper all the time. What we're concerned about, like I said, is not the CNRAs that have been doing good work for decades, who, as I mentioned, Wayne Barker, Wayne does a fabulous job. He serves on multiple committees at the hospital, and he does a fabulous job. And I would have no problems with him taking care of my family, and he has. But what we do have concerns about and where we want to tighten up is that potential loophole as we're seeing some of these having their off-site facilities that are doing nothing but pain blocks, nerve blocks, which we disagree with.
In your proposed piece of legislation, Dr. Hale, you say that if a CRNA administers pain pills, there we go.
Opioids.
I can get it out eventually.
I'm
Pain
glad
pills.
you can't say it. That's a good thing.
That is probably a good thing. That a doctor has to review 100% of those charts. How is that going to increase access to care for my constituents?
It goes back to our other simple versus complex. As I told some of you before, my cousin's a nurse practitioner, does a great job. She worked on the floor for 10 years, worked in the emergency room for 10 years, worked in a clinic for a number of years, and now she's out and has a supervising position. She doesn't need to be overseen on the things she's been doing every day. Right now, that's a burden to her supervising physician. We want to increase her care. We want to let her be able to do more, okay? What we do have a concern is these people are rubber stamping on ADD medications to 30 and 40-year-olds who've never been on them before, to see people that come and say, oh, I need pain medicine because I've got a back. You know, Elvis, as I told you before, had Dr. Nick that could write his pain medicines, his uppers and downers. You don't have to have a Dr. Nick anymore, unfortunately. They're everywhere, and we need to get a handle on that before it becomes a problem. 100% of oversight puts two necks on the block, so we can go after some of these bad people who are overprescribing.
Does your bill address urgent care clinics or minute clinics, as they're called?
Yes.
What does it do specifically?
If they're just doing something simple, as deemed by the supervising physician, and again, I go back to the people I've seen. Well, you can't generalize as far as a nurse practitioner. You can't generalize as far as a physician. Just because I have MD behind my name, you don't know if I'm competent. I like to think I am. You don't have your nurse practitioner. You don't know what their competence level is until you've seen them. An old doctor told me one time when I first started in practice, he said, John, I'm going to tell you something. Some people think I'm God's gift to the world, and some people think I'm the biggest blankety blank that ever lived. He said, but I'm trying to do my best, and that's what it is. With these minute clinics, you go by the individual. If that supervising physician says, yes, I know this person, they've been practicing for 25 years, they can do this, they can do this, they can do this. I feel comfortable with them. You've got somebody on site or somebody reviewing that. If somebody's right out of school, for instance, had somebody call me this week saying, I was supervising a nurse practitioner who was writing marijuana. She said, you can't do that. She said, I didn't know what it was. She said, they just wanted me to refill their medicines, and I refilled it. She said, you can't write that. I can't write that. They didn't know.
Why are we taking individualized examples and painting such a broad brush on disciplines such as the CRNAs, the nurse practitioners? This would eventually impact, I feel, the PAs as well. Why are we doing that when I don't doubt the examples that you're giving? I'm not questioning those, but you're giving just that, anecdotal, specific examples, and we're broad brushing with legislation, and we're using very powerful words such as shall, and we're broad brushing in several entire fields. Why is that okay when and I'm not disputing the examples again, because they should not be dispensing the marijuana and things like that, but why are we going after entire fields?
Yeah. Well, for one instance, the PAs support us in our bill. I think we had some PA. Neutral? Okay. At one time they were supported. Things change, I guess.
Oh, yeah.
Okay. But here's the problem with this. I got a letter this week from a company outside the state who was concerned about our bill. They wanted to set up a lot of clinics here. Our current situation is not working. We've got to do something to work with it.
What kind of clinics were they wanting to set up?
Pretty well urgent care clinics without supervision, or a supervising physician maybe outside the state or somewhere else that would come in and do that. Here's the thing, you can get your advanced practice degree, have a degree in something else, go through the bridge program, and be out working no time at all.
If they receive a certificate of need for these facilities, whether it be an ASTC or whether it be hospice or even urgent care, if they receive that CON, then the CON or the HSDA has decided that there's a need for that in the community. So is that, and therefore providing access to care?
It was not like one of those type of clinics. It was just like a regular walk-in, dock-in-the-box clinic, we used to call it.
Okay, let me be very clear, Mr. Chairman, then I'll hush, but I really appreciate, he's gone, so we can just keep going. Oh, Barry Dawes is here. Oh. No, let me be very clear. I thoroughly, completely, and utterly oppose your legislation. I don't know if I could possibly oppose it anymore, and let me give you a very clear reason why. In Johnson City, where I represent, there is a federally qualified health center. It's called the Community Center. It used to be called the Downtown Clinic. They help people no matter their ability to pay, and they help literally tens of thousands of individuals and families every single year. They provide everything from primary care to dental care to radiology, physical therapy, pharmacy. They have an in-house pharmacy. They run the gamut. They help lots and lots of people, lots and lots of my constituents. They provide access, true access to care to those that are the most needy in my district, in Johnson City, and in Washington County and the surrounding regions. I got to thinking about your piece of legislation. I knew I didn't like it, but I couldn't quite put my finger on it. So I emailed and contacted the executive director of the community center. And I said, would this proposed legislation affect you positively or negatively? Here's several pages saying that it would be negative, to the point of where the executive director stated it would shut their facility down. Patients would no longer have, and I'm quoting now from the email, patients would no longer have access to our nurse practitioners as their primary care provider. You might say in your line of thinking that that's a good thing. Well, what about if we can't find physicians that are willing to come and see those patients? The cost to our clinics, she says, for supervising physicians would increase dramatically. They now pay over $40,000 a year in fees for physician supervision, and the cost will go up exponentially. The burden currently on our family medicine preceptor is more than can be done by a single preceptor for the Johnson City Community Health Center, and another physician has to be called in to assist. This is not the Board of Nursing regulations, but the Board of Medical Examiners regulations that require the burden on physicians. The complex patients, as you spoke to earlier, mentioned in the legislation, she says is within their scope of care. They are capable of managing obesity, hypertension, diabetes, COPD, women's health, prenatal care, among others on that list. If you look on the HRSA website for the ETSU Community Health Center, you'll see that the center is in the top 14% in the country for quality of care for the outcome measures in these areas. The community health centers are expected to provide these services, prenatal care, pediatric care, primary care, behavioral health care, to uninsured and underinsured. Your legislation goes against the federal CHC guidelines for their grant funding. They won't be able to receive any more grant funding, and they will go out of business. The TMA bill also impacts the Mountain City Extended Hours Health Center, the Student University Health Center, 6 school-based clinics, including 3 in Washington County, 1 in Johnson County, the University School, and Northeast State Community College. The clinics combined had nearly 50,000 visits last fiscal year of people that need care. Imagine what will happen to those patients if the TMA bill passes in its current form, and I'll be fair and say in its current form. In the most recent Tennessee Medical Journal, Dr. Hale, you wrote an article, and I saw a specific paragraph that caught my attention. You said physician extenders were created to increase access to care for patients and allow the physician to devote his or her time to more complex cases. Why are we not allowing them to do that with your legislation?
Okay.
Please.
Yeah. Number one, I'm sure they have supervising physicians at all those places you mentioned. And I'm sure they have protocols for that. Do they not?
Yes.
Okay. I don't understand how our bill would cut away their funding for that. Because we're not, if they're providing care to the indigent for hypertension, which we're saying, yes, they can go ahead and do it, diabetes, prenatal care, pediatrics, well child checks, all those things. Our bill does nothing for that. In fact, it frees that up. If it is not a complex matter. Okay, you have somebody that has hypertension that their blood pressure is 145 over 95.
Kind of like mine is now.
I don't want to check mine. You have somebody that comes in with a blood pressure of 220 over 120. It's a little bit different situation.
Do we not feel, though, that the mid-level providers, the extenders, if you will, they are trained to recognize and know that type of situation and then refer that to a physician?
What are they going to do? Who are they going to refer it to?
The physicians in our community that are there.
That they don't have a relationship already?
Why would they not have a relationship if they're coming in and signing 10% of their charts now?
Right now, and what you're talking about with independent practice and with our framework, I know that's two separate issues. They would not have a relationship with anybody. They'd be left sitting holding the bag.
But we're not talking about the nurses' bill. They took theirs off notice in good faith to work with the study committee. We're talking about your piece of proposed legislation that would put my community care center out of business, and they would not be able to help 50,000 people in the next fiscal year. The last part I want to bring up, then I'll hush. The classification you said, thank you. That you said in the article of the latest Tennessee Medical Journal, you wrote, Dr. Hale, that the classification of the complexity of the case was determined by the physician and was understood by all those involved. If ever there was a question about what work was to be assigned to the physician extender, the physician made the final determination. Since the doctor was the employer, his or her authority was unquestioned. And so my question to you is, isn't that what this bill is ultimately about, is not having the doctors, or some doctors, I want to be fair, some doctors questioned? If we cannot in our rural communities find primary care physicians, What other choice do we have than to turn to community care centers like the FQHC in Johnson City, urgent care clinics, minute clinics, whatever you want to call them, to provide basic primary care for my constituents? I agree with the first part of your sentence there. The whole point of extenders is to provide more access to care. Can we please start letting them do that instead of passing your bill, which would hinder, if not eliminate, some services like my community health center? Because this is from the executive director. She did her analysis. If your bill passes, they shut down. I cannot and will not be a party to that. And when you do run your bill, we'll re-engage at that time. Thank you for your good attitude and good spirit and putting up with me. This is not meant in any way other than to make my point, which is I don't want my community health center to go anywhere, and I want my constituents to be able to have access to quality health care. And with all due respect, the way your bill is currently written, that would not happen, and 50,000 people in Northeast Tennessee would no longer have access to health care because they would be shut down. Thank you, Mr. Chairman, for that extended allowance of time. I promise I won't talk much anymore the rest of the year. Thank you.
I will hold you to that.
I disagree with the fact that we closed it down. I also thank you for reading my article. You and my mother are probably the only two people who read it.
Any other questions for Mr. Hale? Dr. Hale, excuse me. And go ahead, Representative.
Thank you. Do you remember my name, Mr. Chairman?
Yes, I
can
do.
tell you're struggling with that.
Jeremy.
First of all, I just wanted to say thank you for being here. The interesting thing about where you're at today is this is the people's house. Many voices are heard. And there's a whole group of nurses and people who they were referred to as mid-level providers by people, but they're actually healthcare professionals. And I want to say thank y'all. Y'all stood there for 2 hours. Yeah, that's all right. You can clap for them. And the interesting thing that they're here for is it's not because they're worried about their scope of practice. It's about the people that they take care of. The people that I represent is rural Tennessee, and this might come as a shock to you. And some people, we have a hospital in my district that we don't have an anesthesiologist like we've got here in this committee. We live far out, and they don't have full-on staff. We have a nurse anesthetist. And I just wanted to voice my feeling. Obviously, I'm the one who's carrying this task force bill. If there's anything we do with the other healthcare professionals other than doctors, it shouldn't be to limit anything that's going on in their life. They have proven, especially the ones who have years of experience. And I have, my sister's a nurse, my aunt's a nurse, my mom's a nurse, my wife is a registered dietitian, so healthcare runs deep into my family. And I wanted to give a shout out for them. If they ever were in over their head, the nurses and the providers that we're speaking about that this bill would probably seek to limit just a little bit, they're not going to do anything to hurt a patient. Their whole life surrounds about being a part of healthcare and bringing a wellness and a well-being to the people. And to think that they would just go ahead, if they're over their head, and possibly harm a patient is really narrow-minded, because the nurses and all of the field of nursing that I know, these are people who care deeply about life and care about the patients that they support. So I hope that this bill doesn't go anywhere further than today, and I'm excited about what we're going to do with the task force. And the neat thing, I don't know if y'all understand, that we're bringing everybody to the table, like Julia's mentioned earlier, and we're probably going to exclude the lobbyist. And so we're just going to bring the actual people, no offense, we're just going to bring the actual people that are affected by this and look at what other states are doing. But anyway, thank you all for being here. And remember, like I told that guy earlier, this is the people's house. You walk around here like you own it. But it's also incumbent on every one of us to make sure we're listening to everybody's voice. Thank you for being here.
Thank you, Representative Faison. I will remind the members, if we all want to do personal orders and or talk about other bills, y'all can look at the clock in the back of the room. We do have two other people that are going to testify before us, and I think out of respect to them that we ought to try to limit our conversation to allow them some time. But you guys, I'm going to be a little more lenient. If you guys want to stay here till midnight, we'll do so. So with that said, any other questions for Dr. Hale? All right. If not, our next person to come up will be Tasha Alexander. Tasha, please come to the microphone and identify yourself.
Thank you, sir. I'm actually here just to introduce the Tennessee Association of Nurse Anesthetists, our current president, Terry Durbin. She's a practicing CRNA, she's an educator, and she traveled here from Knoxville to provide testimony on behalf of our more than 1,900 members. So thank you.
Okay, please state your name for the record.
My name is Terry Durbin. I'm the president of the Tennessee Association of Nurse Anesthetists. Members of the House Health Subcommittee, thank you so much for allowing me. Can you hear me? I'm rather short, sorry. Allowing me to speak to you in opposition to HB 861. I'm a practicing CRNA, I'm a nurse anesthesia educator, and I'm a program administrator in Knoxville, and I'm a very concerned citizen. The Tennessee Association of Nurse Anesthetists represents more than 1,900 certified registered nurse anesthetists and students in Tennessee. We are advanced practice nurses registered by the Tennessee Board of Nursing and are the primary anesthesia professionals in many rural communities. If passed, this legislation will have a dramatic and negative impact, thank you, a dramatic and negative impact on CRNAs practicing in Tennessee and on the patient populations that we serve. The TMA claims that the bill would change the relationship between physicians and APNs from supervisory to collaborative. But when you actually read the bill, it's clear that they are seeking to impose physician supervision, not collaboration. The bill would require that all APRNs practice as part of a physician-led care team model. An APN could only practice acts expressly delegated to them by the physician. Every day, CRNAs make decisions about how to provide safe and appropriate anesthesia care based on their training, education, and experience. This bill would negate all of that, mandating that the CRNA only perform acts expressly delegated by a physician. Further, the bill would take authority from the Board of Nursing and give it to the Board of Medical Examiners. It does this in a two-step process. It defines complex medical condition in the broadest possible terms, including such things as the natural state of pregnancy, and then specifies that a decision made by the Board of Medical Examiners on the complex medical condition is going to supersede any decision made by the Board of Nursing. This bill isn't about ensuring access to health care for patients. It is about restricting an entire group of healthcare professionals. It would require every APRN to have a written practice agreement. Routinely, CRNAs practice with multiple physicians a day. How is that even workable? Can you have a written practice agreement with every single physician you work with? It's not practical. It's not workable. This type of restriction is unneeded and unwarranted, and we already have rules and regulations in place that govern anesthesia practice. Lastly, this bill omits the grandfathering provision for advanced practice nurses. This one provision in the bill could negatively impact more than half of our membership, effectively eliminating them as advanced practice nurses, jeopardizing their livelihood, and jeopardizing the patients that depend on them. It goes without saying that this is catastrophic. We're talking about CRNAs who've been caring for your constituents for more than 20 years. Again, I ask you, is this bill about ensuring access to care, or is it about restriction of care? Let me be clear, it's not team-based. It's imposing unneeded and unnecessary restrictions to put nurses back in their place where the physician is the unquestioned authority. Why are we looking in the rearview mirror for solutions when healthcare is evolving and changing every day? The Tennessee Association of Nurse Anesthetists would welcome the opportunity to be a part of a discussion about how to ensure that Tennesseans have access to safe, high-quality health care. But HB 861 is not it. I don't believe that HB 861 has been brought in the spirit of collaboration, but rather is a cleverly veiled attempt to impose a one-size-fits-all model using restrictions, prohibitions, and supervisions, and I don't think it's what we need. As a practitioner and an educator and a concerned citizen, I urge you to oppose HB 861. Thank you.
All right. Thank you, Ms. Durbin. Are there any questions for Ms. Terry Durbin? Yeah. All right. Go ahead, Representative Terry.
Thank you, Chairman Doss. Thank you for coming out here. And just, I think my name's, or my profession has been thrown out here more than once. I am an anesthesiologist, but just for the record, my brother-in-law is a CRNA, and I teach CRNAs, or SRNAs. As well. So I understand the plight, and I understand the issue quite well, and I appreciate you coming out. Thank you.
Thank you.
Representative Favors.
Yes, Ms. Durbin, I have been involved in healthcare for almost 50 years now and was one of the first clinical nurse specialists. But with the additional physician involvement that this bill would require, what is the economic impact you would see? And do you see that they would have the time to oversee this much activity?
In Knoxville, we work very closely with our physician colleagues at the hospital at which I practice because we're a level 1 trauma center. However, rural facilities don't have that level of access to physicians. They just don't. I don't think we have enough anesthesiologists to send them out to all these rural areas to practice supervisory roles in dental offices and clinics. And I think what will happen is those small facilities will stop offering services. And I think patients will lose out.
And one final question very quickly, Mr. Chairman. Most people do not realize the level of education that you have to be involved in to prepare to practice at this level. Would you just briefly explain what your level of education has to be in order for you to be a CRNA?
Thank you for asking that question. In order to be a CRNA, you have to have a 4-year baccalaureate degree in nursing. You have to have at least 1 year of critical care practice as a critical care nurse, and we prefer to take nurses from high acuity backgrounds. And then you have an additional, in our program, it's 31 months of training in anesthesia, and that's specific to anesthesia. We have our students about 60 to 80 hours a week between working in the operating room, preparing for cases, doing case conference, and lecture. We kind of beat them up a little bit, but they have people's lives in their hands, and that's an important thing. And so there's a significant amount of education and training.
Any other questions? All right, Representative Armstrong.
Thank you. Ms. Durbin, is anywhere else in the country where you've seen a demise as far as advanced practice nurses' practice being contracted anywhere in the country?
As near as I can tell, it's the case that advanced practice nursing practice is expanding to meet the needs of patients. We're bringing more and more patients into the healthcare system, and they need care.
So this bill does just the opposite of which the national trend is going.
In my opinion, it does, sir.
Okay. I've tried to research and find any kind of evidence that would support restriction of practice on advanced practice nurses, and I haven't found it. And if you know of any, as far as complaints to the boards or anything like that. So is there any evidence that could support this bill that you know of?
There is not that I know of. I think that our current mechanisms for managing practitioners that might not need to be where they are perfectly adequate. I think that the Board of Nursing manages nurses, and the Board of Medical Examiners and the Board of Osteopathic Medical Examiners manage their practitioners, and I think that that's working. I'm not really sure what Dr. Hale meant when he said our system's not working, because I think it's working pretty well.
Any other questions for Ms. Durbin? All right, if not, we have one other person that wants to testify, Ms. Jill Kinch with the Nurses Association.
Chairman and committee members, I'm Sharon Adkins. I'm the Executive Director of the Tennessee Nurses Association, and I will be introducing Jill in just a minute. But I would be remiss if I did not set the record straight about one point that Ms. Griffin brought up, and that is the fact that the Tennessee Nurses Association did meet with the Tennessee Medical Association on numerous occasions. We were unable, either side, to come to any kind of a consensus or agreement, which is why we support the task force idea to change the conversation and move that discussion out of the political arena. That being said, I would like to introduce you now to Jill Kinch. Jill is a pediatric nurse practitioner who works at Vanderbilt. She is a past president of the Tennessee Nurses Association.
All right, Ms. Kinch, if you would, just state your name for the record, and you can begin your testimony.
Good afternoon, Mr. Chairman and members of the committee. My name is Jill Kinch, and I'm an advanced practice registered nurse speaking in opposition to House Bill 861 on behalf of the Tennessee Nurses Association and the more than 10,000 APRNs in Tennessee. APRNs value the working relationships we have with physicians, and we value coordination of care. Indeed, nurses are committed to coordinating and collaborating. However, today we must disagree with the TMA-supported bill and advise you of the consequences of adopting what is proposed, as House Bill 861 will impede the delivery of care needed provided by advanced practice registered nurses to Tennesseans across the state. Tennessee APR practice regulations are already among the most restrictive in the country. Most states are moving in the other direction by easing regulations that call for physician supervision of APNs or mandated collaboration. The TMA-supported bill requires all APRNs to work under the direction or delegation of the physician. Imposing major new regulations regardless of whether you call it supervision or collaboration is unwarranted. This negates the master's or doctoral training, education, national board certification, and scope of practice of the APRN. In fact, national research shows that the increased physician involvement in nurse practitioner practice would increase healthcare costs and is unnecessary to ensure quality care. APRNs frequently care for patients in communities not served by other providers, as we have already discussed. This bill would not allow APRNs to practice as they currently do and would drastically decrease access, as many of you have already pointed out. I have a few examples. For example, the West End Women's Health Clinic is one of many Vanderbilt nurse-run clinics, and this clinic would be jeopardized. The West End practice includes 26 certified nurse midwives who deliver over 1,000 babies annually. Another location of the Vanderbilt Women's Clinics provided over 30,814 visits last year and attended to 1,400 births. Also, there is the Vine School Health Clinic, a full-service clinic staffed entirely by pediatric nurse practitioners associated with the University of Tennessee College of Nursing. It is a safety net for families who are unable to find care elsewhere. 90% of the children who use the clinic are classified as underserved and come from families below or near the federal poverty level. 22% are uninsured and 78% are covered by TennCare. During the 2014 to 2015 academic year, the clinic provided 4,442 visits. Also, there are numerous family practice clinics that are run by advanced practice registered nurses across the state. Nurse practitioners bridge gaps in care at the Toby Clinic in Oakland, Fayette County, 30 minutes east of Memphis. The patient population served by this clinic is diverse, including young adults on TennCare with physical and intellectual disabilities and elderly patients unable to find physicians accepting new Medicare patients. Another example is an APR-owned clinic in rural northwest Tennessee that has been in operation for over 15 years and accounts for over 8,000 visits a year. The advanced practice registered nurses at this clinic meet or exceed all credentialing requirements of the various payers. This clinic is a federally designated rural health clinic and provides services to veterans who have difficulty getting appointments at other VA clinics that may be located either 20 all the way to up to 120 miles away. In the greater Chattanooga area, an APRN provides behavioral health in a community mental health center, and she sees 16 to 25 patients from ages 3 to 25 years daily for psychiatric evaluations, diagnosis, and treatment. 60% of the patients have TennCare and 40% are in the Department of Children's Services custody. Some are in foster care, and many are referred from the juvenile justice system for evaluation and treatment. In long-term care facilities or skilled nursing facilities, advanced practice registered nurses are relied upon to provide medical and psychiatric services. One example is Wellness Solutions, which oversees over 80 facilities. Only 5 of the 80-plus facilities where Wellness Solution operates have an in-house physician. The remaining facilities are visited by a medical director who is on site just infrequently, while the APRNs routinely manage the patient's chronic medical conditions, helping them stay out of the hospital. Now, the proposed bill identifies complex medical conditions that require the specialized skills possessed by physicians. These include obesity, pregnancy, chronic disease, and the care of patients under 12 years of age. Nurse practitioners and certified midwives routinely provide this care for these patients now, as we've already discussed here. This increased supervision makes absolutely no sense. APRNs agree that collaboration among healthcare providers is essential. Indeed, consultation is part of our training and does not need to be legislated. What is proposed is not true collaboration, and it does not put patients first. Let us put patients first and discuss how we can add value into our healthcare delivery system. Let's discuss how we can improve access to care. House Bill 861 does not add value or improve access. If enacted, as we've discussed here today already, it causes more problems for our citizens. The best approach is to approve the proposed task force, House Bill 2088, and allow the task force members to develop recommendations that have been vetted by stakeholders from across the state. We urge you to vote no on House Bill 861. Thank you.
Thank you, Ms. Kinch. Any questions for Ms. Kinch? All right, seeing none, we will now go back into session. I recognize Chairman Sexton on House Bill 0861.